It's my pleasure to introduce Dr. Sheldon Landesman and tell you a bit about him. After graduating with honors from Downstate Medical Center, he did an internship at Bellevue Hospital in New York City, followed by 2 years at the National Cancer Institute. He spent the next several years in Boston, completing his medical residency and taking a fellowship in infectious diseases. That's where he spent the rest of his career. He returned to Downstate in the late 70s, just before the AIDS epidemic. Over the next 25 years, he was intimately involved in AIDS, public policy, ethics, clinical care, and research, and made major contributions in the field of prenatal transmission of HIV disease. During this time, he set up a clinical AIDS unit at Downstate, and while serving as vice chair of medicine and chief of infectious disease at another hospital, he set up another AIDS inpatient and outpatient clinic. He also served for 1 year as a special assistant to the New York City Commissioner of Health, helping to control the TB epidemic, which arose in part as a consequence of the AIDS epidemic. He will talk today about his experience in fighting AIDS during the early years at the time of misinformation, fear, and panic, and its impact on civil liberties and the public understanding of this deadly disease. Sheldon.
Thank you very much. Can everybody hear me? Yeah, thank you. Well, first, I'm honored to be here. I thank Stuart for helping to arrange it, and for everybody else, Joel, who made sure I was correct on this. So I want to tell a bit of a history and maybe what we've learned, what we haven't learned from the AIDS epidemic. So I'd like to sort of start with some. So I want to give you some perspective from the beginning of the epidemic. It was, in fact, a perfect stealth disease. It was spread by private, personal, instinctual activities, sex and drugs, okay, which we've never been able to control by the coercive powers of the state. Police states can never control those, okay. It had a long incubation period, on average 10 years, although we didn't know that in the beginning, but it became very quickly clear that asymptomatic people could pass it, okay. It was always fatal, okay, and it was a challenge to how we could control it. In the beginning, we had no agent, no cure, not sure of the transmission. At that point in time, 20 states criminalized homosexual behavior. It was asymptomatic for long periods of time, as I've mentioned, and it had greatest impact on marginalized groups, gay men and minority populations, and IV drug users. And there was no test for the disease. So can you imagine that scenario? That's where we were in the beginning. It was largely ignored by government authorities and by the larger health community because it wasn't their disease. It wasn't in their community. Today, today, in contrast, we have HIV testing, which can identify people who are infected. We have names reporting for the disease for positives. We have no written informed consent. We have blood screening. We have anti-discrimination laws. We have mandatory testing of infants, but not of women, which I'll come to later. And we have effective lifelong therapy, but no cure. Once you're infected, you are infected for life, and you're infectious to others for life unless you continue to take your medicine. And now the majority of people with the disease are what is called totally suppressed, by meaning they're taking their medicines, the amount of virus in their blood is sufficiently low such that they're not infectious at that point in time. This is a disease, although we think of it as something over, is not. This gives you some of the statistics. Nearly 40 million people living with it, 1.3 million dying. These are worldwide statistics. 630,000 died last year, approximately. 80 million infected since the epidemic began, and 40 million who have died of it. In the US, we have over 1 million people with the infection, 36,000 new infections still each year in the US. And we remember that every infection starts from an infected person, okay? Those who don't know they're infected is 15 to 20%. I mentioned a percentage that are suppressed, can't spread. And New York City, we had 1,600 new cases diagnosed last year. So the question then is, how do we control this disease as the cases mounted? In my own hospital in Brooklyn, at one point, 70% of all of the patients on the medical wards were HIV infected, 70%, okay? If you talk to the individuals, the civil libertarians, they were greatly concerned about the rights of the infected, okay? They were worried about social stigma. They were worried about coercive government actions. And the ethical basis for their work or for their philosophy was the autonomy of the individual. No one has the right to make decisions for an individual and their body or to limit their freedom. On the other hand, public health is exactly the opposite. It has a paternalistic ethic to it. The idea is that we do what's best for the community, and if we have to limit the liberties to protect the community, we can do that, okay? And we can use the police powers of the state to do that. All of this dates back to a very fundamental and foundational Supreme Court decision in 1905, Jacobson versus the state of Massachusetts, where people in Boston, the Board of Health there, said you had to take the smallpox vaccination because there was an outbreak. And if you didn't, you got fined $5. Somebody refused to do that. They said they'd had a bad reaction in the past, and it ended up on the Supreme Court. And the Supreme Court basically said that if the benefit is reasonable and the science is reasonable, you can make a reasonable curtailment of individual liberties. Basically, public health acts in the face of uncertainty, whereas civil libertarians only want certainty. And if you think about it for a while, this actually translates out into things much broader than just this particular aspect. And sometimes, if I can interject something a bit different, it gets into politics, okay? I would make a broad statement that Republicans, if I can use that term, Republicans tend to think that you don't have, that the Democrats or the civil libertarians want zero risk of any process or any procedure, whereas others say the economic cost of going to zero risk is too much, whether it be how much arsenic is in the water, the dangers for pollution. This sort of concept of acting under certainty or demanding certainty to protecting the public health is a much, much broader debate. So how do we resolve this tension, okay? Well, it's resolved obviously in the public arena. Scientific evidence doesn't always win, as we saw with COVID, okay? And messaging is key. Messaging is absolutely key to the success of any negotiation of this inherent conflict. Standard public health routines, standard public health measures to control epidemics require examination, testing, mandated reporting of names, contact tracing, sometimes quarantine and isolation, all are designed to slow the transmission of a disease. And we use the coercive powers of the state to do that. I think everybody remembers the case of the woman who was isolated in a tent outside the hospital when she came back from an Ebola area. Standard disease control measures. For tuberculosis, you have to take the therapy, okay? We do contact tracing for tuberculosis. STD clinics have voluntary testing, okay, for everything. There's no written informed consent, and we can actually ask you to name your partners and have them treated, okay? And because all of these efforts are designed to help the community, they are invariably free. Just as much of the COVID work that was done also was free. So to try and deal with this tension, there was a concept that was developed which was called AIDS exceptionalism, okay? And the idea was to sort of avoid gross discrimination against the infected groups. And it was a real fear. Like I mentioned, homosexuality was illegal in 20 states. Gay men feared being ostracized, loss of insurance, job, stigma, housing, etc. In our hospitals, you couldn't get a surgeon to operate on a person who had a history of IV drug use if they needed open heart surgery. They didn't want to do it. They found all sorts of reasons not to, because they didn't want to put their hands into the body and have them soaked with blood from somebody who may be or was infected. The problem was we needed the support of the infected population in order to control the epidemic. If you look at it from an epidemiological point of view, infected people were the disease vectors. The same thing happened with COVID. They were the disease vectors, and we needed them to change their behavior to protect everybody else. We couldn't confine them. We couldn't round them up. There were initial stories about having to round them up. And I was once asked that question. I said, well, if you want to round up 50,000 people in New York City, be my guest. Early in the epidemic, there was attempts by the police powers of the state to control the epidemic. They closed the bathhouses. In our neighborhood in Queens, we had what is now a very well-known art movie theater. Back in the 70s and the 80s, it was a place where you went in with a dry raincoat and came out with a wet raincoat. They closed it down eventually, but it was a huge battle to do so. In San Francisco, where the epidemic was also raging, they had the same battle, What did they do to sort of mediate the risk, mediate the social stigma while they tried to protect the public? Well, one of the messages was everybody use a condom all the time, because condoms were protective against transmission. Now, the truth of the matter is that was a message that was done universally, but it really wasn't necessary. And the reason was when we told our daughter, who was then about 19, I think, somewhere around there, that she didn't have to worry too much about getting AIDS because it really wasn't something that she was going to get, she was outraged. What do you mean? She was truly outraged. But the truth of the matter is, most of the transmission occurred between groups and people and populations that interacted with each other. And it's only the occasional person who interacted with a member of those groups that acquired the disease. But the idea was you have a universal message to sort of decrease the stigma. So if somebody says, gee, you're not wearing a condom, why? Are you infected? The idea was everybody was supposed to do it. So let me go on to give you some of the particulars of what was done well and what was done not so well. The epidemic was first noted in 1981, June, okay. By the next year, there were 3 cases among hemophiliacs. And if you remember, hemophiliacs get what used to be called concentrate to supply the blood factor that allowed them to have blood clotting. So every hemophiliac got the equivalent or was exposed to 9,000 units of blood every time they took a single dose of concentrate. By the end of '82, there were 5 more cases, and then there were transfusion cases. Well, this sparked an enormous panic among the larger general public, because there are 10 million units of blood given out each year, and all of a sudden, us, not them, could be infected. And all of a sudden, elective surgeries dropped because people didn't want to get blood, or they asked their relatives to donate, which sometimes caused problems because if their relatives were gay, they didn't want to tell anybody, and they didn't want to donate blood for their loved one. It created a problem. Okay, so they had a meeting with the blood bankers, the public health officials, the gay community, the hemophiliacs, and all the physicians came to this meeting. The Centers for Disease Control suggested we should question and screen out all people at risk: hemophiliacs, homosexuals, people who had a history of IV drug use, and also because most of the people who had AIDS had evidence of prior hepatitis, as evidenced by an antibody to the hepatitis B virus, that those people should be excluded as well. There was a lot of debate about this. They were concerned that the gay community and the Black community were concerned about the whole idea of bad blood, bad syphilis blood, bad HIV blood, and who should have the responsibility for screening, or who should be donating blood. Jim Curran, who was then headed the CDC task force on HIV, told the gay community leaders who were very involved in it, the medical problem is more important than civil rights. Get in front of the issue. Blood bankers were uncertain, and they said, only 3 cases? Don't overstate the facts. And they were actually resistant to the testing of blood for the hepatitis B virus antibodies. You wouldn't think they would be resistant, but they were. It just shows you the stagnation of cultures that sometimes happen. The gay community opposed any public statement about exclusion of them from blood donation, because it would feel it would be a stigma on them and identify them. Finally, the government changed their policy. No direct questioning of high-risk groups, voluntary deferral, work with groups on issues of privacy, and they dropped the idea of surrogate testing for the hepatitis antibody. Concurrently, there was a battle between the FDA and the CDC who controlled this issue, because the FDA had control over blood, the CDC had control over the epidemic stuff. Gay physicians told their patients a different story. In New York City, they came up with a very unique answer to the problem. Everybody can come and donate, but when you donated, you could check off blood used for health purposes or blood used for research. So if you knew you were gay or you were HIV positive, you check off blood used for research, so that blood will be taken out of the transmission chain and not go to somebody who may get infected. And if you received a unit of blood from somebody who was HIV positive, there was 100% probability of infection. Turns out that 90% of the AIDS cases were people who had antibodies to the hepatitis virus. And like I said, the blood bankers in the beginning refused to do the screening on it. The Hemophiliac Association, because a vast majority of hemophiliacs were infected, maybe 85% of them at that point in time, until they actually developed the HIV test. All of them died. But the Hemophiliac Society told their patients not to tell their sexual partners. They were afraid of the emotional harm it would do. In the end, there was a lot of deaths, unnecessary, and a lot of litigation. Now, birth is a different area because it usually happens in hospitals, and hospitals have control. Governments have control of hospitals. So the question came up once we got the HIV test, which was about 4.5 years later, who should be tested? In New York City, in the late 80s and early 90s, there were 250 babies born each year who were infected. And again, all of them died of their disease. Late in 1985, the Centers for Disease Control recommended that all women at risk to get tested so they can make informed decisions about childbearing. No mention of abortion, okay, but informed decisions about childbearing. And the transmission rate from mother to infant was about 25%. We did a study in our hospital, Kings County Hospital, which was a local Health and Hospitals Corporation in Brooklyn, New York. And 2% of the women, a blinded serosurvey, were positive. 40% of them reported no risk factors for HIV. In other words, as far as they knew, they hadn't slept with somebody who was an IV drug user. They weren't a drug user themselves. So expecting people to voluntarily state that they were at risk and therefore get tested didn't work. A colleague of ours then did a study on what's called the heel stick survey. All newborns get a heel stick with a small amount of blood, which goes to a central lab, and they test for PKU, thyroid disease, and you can actually do it for HIV disease. Turns out there were many more causes or many more positives for HIV disease than there were for something like PKU. When we did an anonymous heel stick study later on in New York City, 4% of all the women born in New York City were HIV positive, which meant about 1% of all the babies were infected. 1987, the CDC, that was still somewhat behind the curve, said all facilities must offer counseling and testing to everybody. It didn't mandate testing. You would think you would mandate testing of all pregnant women for a disease which could be fatal and passed on to their infants. And the interesting thing was the women's group opposed mandated testing. They opposed it. They said, what do you mean? You're going to test us, the women, first? Why don't you test the guys first? We don't want to be the first group to have mandated testing. So they opposed mandated testing. They continued to do blinded anonymous serosurveys. No treatment was available, so they felt they didn't have to inform the women. Sort of remarkable if you think about it. And they created, now that they had the test, they created counseling. You had to counsel the patients if they wanted the test. The counseling was 2.5 pages, took a half hour to do the counseling, and it was really designed to discourage people from getting tested. And they used the genetic counseling model of, well, here's the information, you do what you want with it. In 1990, things changed a bit. There was a push by the pediatric community. We have to know whether the baby is positive when it starts to develop symptoms, because we have to isolate the baby if that's the way. And there is a question of unblinding the survey and telling the women. 1993, there was a baby AIDS bill. They unblinded the survey and they notified the women, but you don't test the women. So here's the odd thing about it. When somebody is HIV infected, they produce antibodies, and all babies born to infected women will test positive for the antibodies to the AIDS virus because it passes through the placenta. So a positive test on a baby means the mother is infected. It doesn't necessarily mean the baby is infected, because only 25% of them actually get the disease. They may have passive antibody, but they may or may not have been infected with the virus. So you were testing the babies, but you were really testing the mothers. This is 100% positivity. But they still wouldn't have mandated testing of the mothers. You would think you would want it before the baby was born or earlier in the pregnancy so they could make their own informed decision. This was not the case. This is where civil liberties and public health didn't work out so well. Finally, a couple years later, a very well-known study called the 076 study came about, which showed that treating mothers who were infected decreased the amount of virus in the blood and decreased the rate of transmission. So that pushed things a bit further along. Now they passed a law which mandated testing of the babies, but again, not from the women. It's hard to know what to sort of say about that that episode in our history, except that we didn't really cover ourselves with glory on it, and the issue of the civil liberties didn't help the women in that area. Let me talk a little bit about HIV testing. We didn't get the test until 1985. And again, once the test came into being, all of a sudden you could identify people who were HIV infected. So what do you do with that information? Can you give it to an insurance company? Can you require it for health insurance? Could you require it for life insurance? Do you keep their names in a registry the way we do for tuberculosis and many other diseases? There was a great deal of angst around this particular issue. In 1988, they passed a law criminalizing release of HIV information to somebody other than the patient or somebody who the patient authorized. But we still didn't routinely test patients coming into the hospital, which is where you would think more than ever you would really want to know so you could treat their disease. It would require this extensive counseling that was done, which tended to discourage testing. The question now is, if you think about what do you do when you discover that you're HIV infected, it imposes a serious ethical burden on the infected person. Do you tell your partner, and you probably finish off your sexual life, at least with that partner? Okay. Do you not tell them? So it was a real ethical dilemma. And to this day, it is a still ethical dilemma for patients who aren't fully virally suppressed. To this day, if you're infected with the virus and you don't have very, very low viral levels, you still can transmit the disease to others. So there was a real ethical conundrum about getting tested. And in the beginning, many people who were at risk for HIV did not want to get tested. And their community supported them in that in the beginning. It gradually changed as therapy became available. So to some extent, the epidemic has cooled in part because we've had the science, which has given us some effective therapy. In 1985, the very first drug came around. it wasn't very good. 1995, we had the first reasonably effective drug in combination with others. And by now, we have these 3 or 4 drug combinations with a single pill, which if you take it, and you have to take it for life, can keep your viral load down, and you could decrease your ability to transmit to somebody else. And now we have something called PrEP. PrEP is where men who may be at risk or consort in a community where they may acquire it can take a medicine before they have sex, so they are partially protected from acquiring the disease during sex. There was, I said, a great deal of angst about the issue of what to do with people who are HIV positive. It turns out the issue on health care per se was resolved in the sense that insurers could not ask for purposes of health care whether you were HIV positive. They could ask for life insurance. If you looked at the consent form for HIV, it was rather peculiar, okay? It said, this test for HIV is not a test for AIDS. And many of you have probably heard that there's AIDS and there's HIV. That was an accident of government naming. AIDS is just end-stage HIV. That's all it is. It's end-stage disease. We've kept it up because if you have AIDS, you're eligible for more government benefits. But AIDS and HIV are really the same disease, okay? But the counseling that you had to give the patient was, it's not a test for AIDS. It says, if you're positive, you've been exposed to the virus. Not that you're infected, but you've been exposed, okay? And the one I thought was the greatest one was on the counseling form, said if you're positive, you may suffer psychological harm if you find out that you're positive. Now, can you imagine if a woman is going in for a mammography and you have to sign a consent for it, and it says, if we find cancer on your mammography, okay, you may be upset. That's what we did. But we needed to know who was positive and how the disease was spreading. So surveillance of the positives was important. So to this day, health departments and the government do keep track of positives, but there are very strong protections against revealing them. And one of the things, probably the only thing in this world that hasn't been hacked yet, a list of HIV positive people that reside in city boards of health and in the national database. Finally, eventually, New York State, and I'm sorry, I'm speaking here in New Jersey, but I'm talking about New York, finally passed a law saying you did not have to do counseling. You have to do written informed consent. You could come in the way you go to a hospital now, they draw blood for what they call routine things. There was good evidence that the counseling for HIV discouraged people from getting tested and slowed down the control of the epidemic. Nowadays, that era is over. We report positives, no written consent, blood is screened, anti-discrimination laws, mandatory testing of infants, but still not of mothers, okay? And many drugs for HIV still in the pipeline. I seriously doubt if we're ever going to find a drug to cure the disease. But it's lifelong treatment, but sometimes it's pretty uncomfortable. The epidemic sort of smolders on. To give you some, the thing that sort of has bothered me in the past was this issue of the ethical responsibility of the infected person. So an infected person, whether it be COVID or whether it be HIV, is really a disease vector for their disease. And there has never been, as far as I'm aware of, in the public health sphere, the idea, the message that an infected person has an obligation to their sexual partner. It's in the sexual marketplace, it's still caveat emptor. Beware on your own risk. And actually, I will tell you a very famous article in the Wall Street Journal back in the earlier mid 80s. Actually, it must have been mid 80s. William Buckley wrote a piece in the Wall Street Journal trying to figure out how we could prevent transmission and still be cognizant of civil liberties. And he suggested in this article that all people who were HIV positive have a tattoo or a mark on their buttock. Needless to say, he was vilified in the press. But if you think about it, you know, it keeps it private, keeps it between people who are about to engage in sexual behavior. The other thing about this epidemic, and probably relates to others, is that who is left, who is still getting infected? Sometimes it's young gay men who are just initiated into their culture. Sometimes it's people in the marginalized community who may be using drugs. And oftentimes it's people who have mental problems or IV or substance abusers. They can't hear the message of their own safety or others' safety. And that's a group that's going to be very hard if we can ever reach them. There are many analogies to this in relationship to COVID, but I think I would just sort of stop now and take any questions anybody has. Thank you.
Ronald Weinger. Is blood donations, are they routinely screened now for AIDS and whatever?
Yes. Blood is routinely screened for about 30 different things, one of them being the HIV test.
And Rich Lander, I've heard recently. Okay, thank you. Rich Lander, I've heard recently of increases in TB and leprosy. Is there anything from these situations that we should learn as a society?
Well, the leprosy has gotten a big play in the press because there were a few extra cases in Florida, and all of a sudden, the Florida Bureau of Tourism was really lambasting the CDC for these few cases. But there is a lesson from TB, and that is that back in the early 1990s, we had an epidemic of TB in New York City, and it was drug-resistant TB. And the fear was that we would lose all effective therapy for tuberculosis and we'd be back in the 1920s. I was working in the city Department of Health then, because it takes somewhere between 6 and 9 months or 9 months and a year to effectively cure somebody from TB, which is a respiratory disease. And we would have people coming in, being treated, and then getting lost to follow-up. And if you interrupt the treatment before a complete course, there is a significant probability of relapse of the disease. But having been treated, stop the treatment, and then have the disease come back, it usually means the organism is drug resistant. So the problem was, because many of these patients in marginalized communities would get TB, would be treated for a while, stop the treatment, and then we'd see them in the hospital a couple months later, they now had drug-resistant TB. So we had to stop that. And what they did was they created a law in New York City, which said, if you miss 2 successive appointments for your tuberculosis treatment, or you're lost to follow up once, and then you're lost to follow up a second time, We can lock you away. We can put you in a sanatorium and require that you be treated until you're cured, because we couldn't have people with drug-resistant TB going around. People were afraid to go on the subways, et cetera, et cetera. And it was sort of complicated because, you know, the order to sort of confine somebody was issued by the Department of Health. But because you can't simply restrict somebody's liberty by an order like that, okay, you had to have a hearing where it turns out you would restrict their liberty, but then they had to go to a court. Well, the cops didn't want them in the car. You're going to put me in the car with a guy with drug-resistant TB? The cops said, no way, okay? The judges didn't want them in the courtroom. You're going to bring this guy into the courtroom? No way. So it was very difficult to sort of solve this problem. We eventually did. Some public healthcare workers did a lot of the work. But it's an example of how the state can use its police powers to limit somebody's freedom for the benefit of the public, but they had to use the least restrictive alternative to do so. It's a combination of the two.
I was born, I'm the third of three boys. And we all inherited the open heart surgery. I inherited my open heart surgery was done in 1995 at Morristown Hospital. As a result of the condition with HIV, I wasn't allowed to have a blood transmission during or after the operation. It resulted in my having anemic for quite a few years after, but before my blood turned normal. I was wondering, is there a large number of people that were in this situation?
Well, it's clear that open heart surgery, unless it was immediate and necessary, decreased during those years. Once they had the HIV test, they could screen the blood. So it was easier to get the surgery done then. So we don't have that problem anymore.
Thank you.
John Tomaszewski.
Yes, hi. Thank you for a great talk. I really enjoyed it. I used to give blood on a regular basis. And then what happened was I went in to give blood and they told me you have HIV. And so needless to say, I was really concerned about it. Nobody else seemed to be very concerned. And what I found out, because I did get tested later by a doctor and I didn't have it, but what I found out was at that time, I don't know if it's still the same, when they give you when they test the blood the first time, if there were a lot of false positives. And I was wondering if that still happens. And I'd also like to know, you said you didn't tell your daughter to worry about HIV. And I wondered if you could talk a little bit more about that too.
Well, to your first question, the HIV test, as it was originally designed, which was an antibody test, was fairly sensitive and fairly specific. But if 1 out of 1,000 tests are false positives and you're testing 10 million people a year, you're going to have a lot of false positives. Now, that problem was eventually resolved by 3rd and 4th generation tests, and also when they developed tests to actually test for the virus itself. So if you test for the virus itself on an equivocal test, you can tell whether a person is infected or not. With regards to my daughter, okay, like I said, she had been schooled on the idea that everybody is infected. And I said, it's probably not true. Not that there isn't a risk, but the way sexually transmitted diseases work is there are certain groups of people for whom the infections of sexually transmitted diseases circulate among that population. And when somebody who is not part of that population enters that group, they're at risk of acquiring it. And I said to Molly that she's probably not part of that group, but she can do whatever she wants. I mean, you know, she was, yeah. But she was shocked. She said I was doing something against public health.
Are there more questions? Well, I'll ask one, and it's a different kind of question. Looking back on it, you criticized the CDC a little bit and the FDA. Is there something that could be different that would make them better? And is the CDC in some kind of a decline, or should we feel that they're doing a pretty good job?
A couple of responses. One, the CDC almost always, when there are epidemics, has to deal with the aspect of uncertainty. So an uncertainty can always have two sides to it, you know, you either act or you don't act. And most of the mistakes they make are unintentional. And because they're trying to do, they have a sort of utilitarian basis of trying to do what they think is best for everybody. But you don't know. It's a bureaucratic organization, but it has a lot of devoted people in it. Sometimes, so to tell you a very quick story, when we had the anthrax scare after 9/11, I don't know if you remember, there were anthrax envelopes with anthrax spores mailed to the news media and the Democratic politicians, and you could get a medication for it, ciprofloxacin, which could be used for it. And the CDC said, "Don't worry, we have enough ciprofloxacin for it." That was bullshit. To be very frank, if somebody dropped a 500-pound bomb with anthrax spores over Washington, D.C., it would kill 1 million people. So they didn't have, they were doing that to reassure the public and not to run out of Cipro when they needed it for people. So those are calculations that they make. Other than that, I think they're a good agency that do a lot for us.
Yeah, I think you called me. I couldn't hear you, but anyway, thanks for a great talk. I think this audience, I expect, very few of us know anyone with AIDS. We're kind of isolated. Well, anyway, but I'm very interested in the lessons for dealing with COVID, and I'd like to hear some comments on that.
So, again, what are the lessons for COVID? I mean, that's a hard question. The first is that messaging is everything. Public health doesn't exist without good messaging. And so in the beginning, for example, Anthony Fauci, okay, advised, don't wear masks. And he's been pillared by the political community on that. And the reason in the beginning was because they didn't have enough masks and they wanted to save them for those at most of risk. But that got lost in the messaging of the disease. I suspect that the initial plan to sort of do lockdown and keep kids at home didn't turn out so well. That it destroyed economics and it clearly decreased the ability of the kids to learn. And I think part of the problem with COVID was that we got caught in the political maelstrom of the divided nation. So everybody was their own individual autonomous person without paying attention to community. And as we know now, many people are data resistant to real common sense things. So I think the political environment did that or exacerbated that. In 1947, there was an outbreak of smallpox in New York City, and 2.4 million people lined up to get vaccinated within the first 2 months. There wasn't any issue of whether you can or can't or should or shouldn't. We don't have that environment now.
First, a quick bona fide. I worked for the company that isolated HTLV-3 for the NIH and developed the first test for the antibody. But I have a question now about what's going on today in the schools. Our young children are being, in some schools, I understand, are being told that they can choose their gender, and they're being taught behavior that is conducive to the spread of HIV. Is there any evidence that that's having, it's a little early, but that is having any impact on AIDS infection?
At this point, I think I can say fairly conclusively that there's no evidence that sex education, whatever it is, has increased the incidence of HIV infection. So I think at this point in time, it must have been a very exciting time with in Bob Gallo's lab.
Did you happen to know Matilda Krim?
Yes.
Fantastic.
Dr. Landesman, first, thank you for the work that you did in the early days of the epidemic. I'm sure it could not have been easy, and I'm sure we're all grateful to you for that work that you did. Question. Question, knowing what you know now, if you had been the AIDS czar back in the day, what are the 2 or 3 things that you would have done to cut down on the number of deaths?
Well, that's actually a hard question. I guess it took a fairly long time to get facilities up to care for the patients. Once we had treatment, it helped a great deal. There was at one point during the epidemic, I was asked by a reporter, because the great risk was heterosexual transmission. That was the great risk, okay? I was asked by a reporter, are they going to give it to us? And I replied, well, they are us. That's, if we are a community and members of our community are ill, we have to do everything we can. The president of our medical center, so to speak, ignored the epidemic for the first 5 years. And then finally, when doctors didn't want to come there to train, medical students didn't want to come there because they were afraid, okay? He decided to create a committee to study the problem. I was head of the scientific part of that committee. And we gathered in the president's office, and he said, we finally have to deal with this disease because we don't want to become an AIDS hospital. And I said to him, Dr. Shaw, I'm sorry, but we did a sero survey last month, and 70% of the patients in the hospital are already infected with the virus. So we are an AIDS hospital, and you have to figure out how to do something about it. And he looked a bit nonplussed by it. And I reminded him that, 40 years ago or 50 years ago, it was polio in the hospitals. And before that, it was staph or strep in the hospitals. And before that, it was tuberculosis in the hospitals. So we've managed to surmount all of those, and we will surmount it again.
Thank you so much, Dr. Landesman. I think we're finished with questions. Oh, no, we have one more. Come run up.
I hope you were singing along with us. I have a trivial question and sort of an unfair question, but since you've brought up politics, or somebody has, I'll mention. The first one is, I seem to recall that in those days when there's questions about keeping the blood supply safe, but also respecting everybody's liberties, was there a time when they would do the testing and allow anybody to give blood, but the bloods that came from people whose results were positive for AIDS, they just would discard it. So nobody was told they couldn't give blood, but they didn't use that blood. It wasn't a question of sending it to research, but just throwing it out. And wait, so that's the one question. The other is, this is at the other end of the spectrum. If President Ronald Reagan had not been refused to acknowledge AIDS while he was president, would that have changed the trajectory of the whole story?
Well, that was an answer to your second question. That was the thesis of a book by Randy Schultz called "And the Band Played On," which is a history of the early epidemic. I don't think it was probably true, because if you look at the history of the disease, things moved very rapidly. We identified the agent within 3.5 years, took 10 years. So I don't think it was bad for the social milieu, but not in terms of blood testing. Once they had the test, they obviously tested all blood. And then the question was, do you notify a donor who didn't know that they were positive, that they were positive? And that was called a look back program. And that was initiated. They did that. But that, yeah. So,
Thank you again. This was a terrific talk and so stimulating and really adding to our knowledge.
I think we have all learned a lot, and we're really grateful that you were able to put in perspective one of the most important historical challenges that we've had in modern times, and your role in guiding others and explaining to us about the AIDS epidemic was truly marvelous. We also give a certificate of appreciation from the old guard, and there happens to be an orchid on that because in 1930, when the old guard of Summit was founded, Summit was the eastern capital of orchids. And I think had my wife and I been around that time, we would have made very good use of purchasing orchids. We love it. So thank you very much.
thank you, Stuart.
Really appreciate it.